introduced new national guidance. So this is our first ever training on the new national guidance based off of the Council on Mental Health and Wellbeing. So we're glad you're here. You're going to get some brand new news and information and a different way of looking at how you measure or view your integratedness in your clinic. So thank you for being here.
Thank you, Kara. And as Kara mentioned, it's a lot of new faces, so we just want to share a bit about our organization. So Mental Health America of Greater Houston drives community solutions to promote mental health for all. And we do this by using education, advocacy, and collaboration to drive systems change. And the purpose of the Integrated Healthcare Initiative specifically is to create partnerships, provide leadership and vision, advocate and educate, and provide technical assistance to implement and sustain efforts that promote integrated care. So our vision is for integrated healthcare to be accessible, cost-effective, and the standard delivery of care for all. And so for today, our learning objectives are to discuss the key elements of IBH and associated models, which is a refresher of IBH, Intro to IBH Part 1. Describe the 8 domains and associated subdomains of integration, define the 3 constructs to greater integration in each domain and subdomain, and also to describe the metrics of integration. And so we want to know who is here with us today. So if you can just please enter into the chat what best describes your role. So potential clinician, administrators, clinician, TA quality assurance. Okay, so we have a good varied bunch. That is awesome. And then Sujina, if you can go to the next. So we also want to know where your organization is in the process of integration. Is your organization learning and exploring? Are they already beginning to implement? Is it already completely implemented? Okay, learning, exploring. Implemented, awesome. Advanced, ongoing, quality improvement. Okay, so again, we have a good varied group today. Thank you all for chiming in. And we do ask that if you have any questions throughout the presentation, because it is very content heavy, just feel free to put that little sign with your hand up and we'll be sure to get your question answered. So I'll go ahead and pass it on to Alina now.
Hey, Alina, you're muted.
Oh, sorry, guys.
Okay.
Thank you, Victoria. So as Victoria mentioned earlier, one of our objectives today is to provide you with a refresher of what we had presented last time. And so we're going to start with the definition of what integrated behavioral health is. So according to the Agency for Healthcare Research and Quality, integrated behavioral health is the care that results from a practice team of primary care and behavioral health clinicians working together with patients and families using a systemic and cost-effective approach to provide patient-centered care of a defined population. The team addresses mental health, substance use, and behaviors that affect physical health, which are identified during the primary care visits. So now we're going to talk about the key elements that make up IBH. So again, if you've attended one of our previous trainings, we spoke about how there are two different models that you can adapt under IBH. And with that said, it doesn't matter which model you choose to adapt for your clinic, but it doesn't matter which model. However, the key elements are still the same. Like this is our primary focus on the quality of care that comes with integrated service delivery, starting with the fact that it is a person-centered team or patient-centered team that is collaborative. So this is where the teams learn to work together and make decisions collectively while keeping the behavior and physical health in mind. Then it should also be population-based care where the team or the clinic decides on targeting one population. And by that, what I mean is like one type of diagnosis, like maybe you just want to focus on anxiety or just one defined population in the clinic to improve outcomes. And we'll talk about this again later in the presentation. And the next key element is measurement-based treatment to target care, which is where the treatment plan should be actively changed until you meet all of your clinical goals. Then it should be evidence-based care, where you utilize brief interventions, evidence-based brief interventions, psychotherapies, motivational interviews, to engage your patients in their own treatment plans. And lastly, we want to make sure that IBH is all about patient experience. We really want to make sure that through this type of service delivery, our patients experience that one-stop shop where they feel like both their physical needs and their mental health or behavioral health needs are all met in one single location, and their care team cares about their overall health than just keeping them separate. And now we can move on to the different types of models that I just mentioned. So, like I said, there are two widely adapted models of IBH. The first one being primary care behavioral health. We refer to it as PCBH model. And the second one being collaborative care management. We refer to it as COCM model. So the main difference between that is we're focusing on the left side of the Venn diagram is that the PCBH model contains a behavioral health consultant or a BHC that is part of the team. So this person can be a licensed clinical social worker or a counselor or a family and marriage therapist or even a psychologist. And these individuals are handed off from the PCP to conduct their brief interventions. PCPH models utilize evidence-based behavioral treatments customized for primary care, and they're usually not for very complex cases because they're for more short-term treatments that can last less than 6 sessions. So they can be dealing with small, like preventable conditions or something that's not as severe and need complex treatments. And as for the collaborative care management or the COCM model, that's exactly what they do, right? They take care of complex behavioral health needs. So they have a behavioral health care manager that is part of their team, and their decisions support for a complex behavioral health needs provided either by a practitioner or a psychiatric consultant. They also utilize a registry for patient tracking and follow-up monitoring. And again, they do long-term treatment where it could last from 3 to 12 months. So I've talked about the differences, and I think the Venn diagram does a good job of identifying what's common between them. And it's that these type of models, they help with cost savings or with your expenses. They're also both team-based care, and they both have some sort of behavioral health provider on staff in your team under the same roof, working towards patient care. And they both use evidence-based screening with diagnosis. So if you guys want to learn more about this, we will be providing additional trainings as we go forth with our series about more that talks more in detail about each of these models. So now we've briefly talked about what integrated behavioral is, and now we're going to talk about what it's not, right? So because behavioral health is such a new and complex idea, and there are so many misconceptions around what it could be, right? Starting off with the fact that if your clinic is providing co-located physical health and behavioral health services in the same building or in the same floor or next door, then it does not mean that they are integrated. In order to deliver integrated care, you need to have them part of your primary care team and work collaboratively under one roof in the same clinic, working on the same patients at the same time. It also, it's not IBH if you consolidate separate funding for physical health and behavioral health care just because you've set aside money for these IBH efforts does not mean your system is fully integrated. And it's not about putting physical health and behavioral health services under the same lines of authority. Integrated care is, it's not a one-person job, and it's definitely not a single authority job. Like you need your entire organization involved in the process of making your integrated behavioral health fully and systematically integrated. And lastly, just because you have a contract with a MCO, which is a managed care organization to manage both your physical health and behavioral health services, does not mean your system is integrated. So none of these listed bullets are sufficient enough to provide integrated care. And as we mentioned earlier, and as we're going to talk about the new framework, there's so much more that goes into completely changing a system, right? It means that you need to have the right leadership endorsement, you need the right funding, you need under integrated care. And so now I will pass it on to Sujina, who's going to introduce the new framework to you.
Thank you, Alina. Can you guys hear me? Yeah, okay. Thanks. So now that we've discussed what integrated behavioral health is and their elements, the two models that Alina just went through briefly, let's talk about the new framework for system integration, which was introduced to us last year. So the Comprehensive Health Integration, also known as the IHCI, they have put together a framework which was developed by the group within the Institute of National Council. They put together an expert panel, which included payers, policymakers, American Psychiatry Association, Psychology Association, SAMHSA, HRSA, CFHA, and many other stakeholders were involved. So this new framework was definitely a collaborative effort to promote advancement of integration in a more comprehensive way throughout the nation. So you might be wondering, why the new framework, right? Can we not work with what we have so far? Well, there are many reasons to why, but these are some of the most common ones. So many health organizations have not attempted to implement any of the current models. Many studies have been done on those models. We have good research out there now, but they still have not been widely, adapted or used as the overall standard in the field. Or they're often implemented as an isolated program, separate pilot services instead of a whole organization transformation, or that they're not able to sustain or expand beyond the initial grant funding. Even if the implementation was successful, they were not able to keep going because the initial grant ran out and therefore the program went away. So why are we in this situation, right? Even after the decades, we're still not able to commit and successfully implement integrated care. We started off with the 4-quadrant model, like Kara mentioned earlier. There have been many establishments, within all these decades. There was the 4-quadrant models, the 3-level of integration, the SAMHSA's 6th level of integration, which is prominent in the field right now. And looking at all of the existing models that we have good research on what is best practice, what makes collaborative care model work, what makes the primary care behavioral health model work. The research has been happening, and there's evidence that shows, improved clinical outcome as well. But in spite of all that, there's still barriers that exist, like lack of flexibility in implementing, saying that if you do not follow or implement every component of the model, then you're not integrated. And maybe there's a need for a more incremental, broader approach. It has also been it's been difficult convincing our payers at the government level, or managed care. They like the idea of integrated care and are willing to pay for it, but we're not able to show value on how integration is really improving performance measures. And because we do not have a way to connect our integrated care to the true value, and our payers, they really want to see value. They want to find integrated care programs that actually demonstrate people get better. And this can fall short if we do not have outcome measures. And because the payers and the policymakers, they really want to see value. And because we're not able to demonstrate that value, therefore we do not get the financial support. So this is where the CHI framework comes in. It's designed to address those barriers. This new framework emphasizes that the bi-directional integration is critical. We need to prioritize patient-centered care. So we need to bring integration to where the patient is. Therefore, it covers both aspects, physical health and behavioral health. So if you're in a behavioral health setting, you need to pay attention to the physical health need of your patient. And if you're in a primary care setting, you need to pay attention to the behavioral health needs of your patient in order to provide that patient-centered care. And this framework is also designed to advance integration for providers, for payers, for population managers particularly. It provides guidance on how to measure progress as you are advancing integration, as you're moving from the earlier stages of integration to the more advanced stages of integration. It allows you to demonstrate value that your organization has produced as a result of your integration. It also provides guidance and recommendations on the funding mechanism that are appropriate for both initiating the integration and sustaining it. So really quickly, let's go over the key components of the framework. So there are 8 evidence-based domains, which are going to be your care processes. They address both the physical health and behavioral health again. It gives you the exact list of tasks that you need to be doing with, of course, some flexibility. There are 3 constructs, and Alina is going to go more in detail. She's going to thoroughly explain the constructs to you all. They're called construct, and those 8 domains are measured under those constructs. And if I could put it in a simpler way, you can just think of it as your buckets, the 3 buckets, your beginner, intermediate, and advanced bucket. As you do the self-assessment on those 8 domains, you'll see where exactly you fall in within those 3 buckets. And then there is integration metrics, which will allow you to connect your progress to the metrics. And then lastly, we have integration payment methods. So we're going to go through most of them here today, but before we move ahead, I also wanted to provide you with some lexicon for the new framework. These terminologies are commonly used in this framework, so just wanted to provide a quick description. So when integrated services are mentioned, it is defined as physical and behavioral health interventions that are appropriately coordinated by the treatment team using appropriate interventions for physical health and behavioral health conditions. And then the word integratedness is non-existent, but here they are using that as a terminology for degree to which programs are organized to deliver integrated physical health and behavioral health prevention and treatment services with consideration to the social determinant of health. And then lastly, the bi-directional integration, which I have already mentioned earlier. It's when you are integrating physical health into behavioral health setting or integrating behavioral health into the physical health setting. So with that, I'm gonna pass it over to Alina to talk about the constructs.
Thank you, Sajina. Can you give me remote control, or do I already have it? Oops. All right. So now we're going to talk about the constructs, which is a big part of the new CHI framework. So for those of you who joined us in our last session a few weeks back, we showed you a snippet of the construct And now we're going to be breaking it down for you, starting with the core components. All right, so first things first, as we move through the domains, you might start to notice that the constructs and the domains, they sound very similar. And that is because the constructs are drawn from the domains based on the measurable processes that have shown direct improvement in health outcomes. And they're also drawn from the 8 domains to describe the evidence-based and expert-supported service elements. So really, it's intended to provide some sort of flexibility for the implementation and utilization of integrated service delivery based on the organization's mission, resources, incentives, and capacities. So earlier, Sujina talked about barriers, and the biggest thing was the lack of flexibility in how to implement this. So that's exactly what these core constructs are trying to get at. And they also develop the constructs to provide some sort of adaptability in consistency with what you are doing to get to the higher levels of integratedness. And so the end goal really is to make sure that everybody is on the same page, kind of taking similar evidence-based steps towards integratedness with what they have to use, considering their resources and incentives and capacity. So now these are the 3 integration constructs that you'll be hearing a lot moving forward in this presentation. So now keep in mind that the nature of these 3 integration constructs is to, again, measure the progress of where you are in the process of integratedness by monitoring yourself and making improvements where you can at your organization or clinic. So ideally, you will need to show how many of these targets that you have achieved under each of these constructs to demonstrate measurable value, which we'll talk about later in the presentation. But you want to demonstrate value under each of these constructs to have you get paid for your efforts from the payers. So the first one is screening and enhanced referral. Once you achieve that, you move on to care management with consultation. Then the third one, which is also the most advanced or the fully integrated construct, is the comprehensive treatment and population management. And as you can see here, each of the constructs are progressive and advancing to the next one. It requires that you implement the elements of the prior construct. So in other words, you cannot skip the steps or pick and choose what you want to do. Instead, you must build on each of these constructs. And again, there are flexibilities under each of these constructs to ensure that it aligns with your clinic's capacity and capabilities. So now let's move on to integration construct 1, screening and enhanced referral. So what exactly is this? So with this construct, the ultimate goal is to optimize your screening and enhanced referral process. So what that means is that instead of saying like, hey, it sounds like you might have depression and you should really go see someone, let me know how that works out for you, you develop a organized process at which you have a MOU or a partnership with a behavioral health services clinic where you have the authority to organize communication around referrals or following up and tracking and actively engaging the sharing of patient information, like simple things like if they even made it to the behavioral health appointment, or if they needed some extensive tests, did their test was their results positive or negative, right? And most of the time, it does not require any significant investment in terms of finance. However, this may not always be possible for all of the clinics because one, either there might be a provider shortage for behavioral health entities, or some of them, even if they are right next to you or down the street from you, they just might not be willing to develop this collaboration or partnership to conduct a successful enhanced referral process, right? So a lot of the times what clinics do is that they hire an internal staff or an internal behavioral health provider that can take these referrals, but then it ends up being simply co-located care. And at that time, it's like the PCPs and behavioral health providers, they're not properly communicating about their patients. They're not participating in the enhanced referral process of, again, sharing the information, their results, their timelines. And the ultimate goal, as I mentioned before, is that we want to be able to successfully implement the screening and enhanced referral process, even if that means co-located care. So that doesn't mean that you have one PCP and one behavioral health provider under one roof, and they have the same line of authority, but they have no idea what patients are coming where, what's going on in the other person's clinic. And so once the clinics can successfully implement this construct, it can result in an improved routine screening of basic physical health and behavioral health conditions, because now the referrals are being tracked, the results are being communicated, and high quality treatment is provided. And the purpose of this is that it develops a purposeful and planned partnership between the physical health and behavioral health practices on shared patients to improve their access, their timelines, and their overall quality of care. So now let's flip the lenses and see, how does the fully implemented construct 1 impact the patient's experience, right? So, well, like the patients, they will start to feel like the providers in different locations, like 2 separate locations, are working together to address both their behavioral health and their physical health needs. So instead of you being the middleman that has to, let's say, like, you have to call your new therapist, or you have to call your new behavioral health provider and be like, hey, can you transfer my records to my PCP? It kind of becomes like an automated process for you. The doctors are communicating your treatment modalities amidst each other, and they're bettering their communications. So, and then when you're in the PCP's office, you notice that the PCP is interested. They're actually interested and invested in wanting to identify your behavioral health condition, and they're facilitating the communication through referral to their behavioral health partner, and they're staying on track with following up. And then when you're in the behavioral health setting, they're not just trying to address your behavioral health needs, but they're also trying to give you a similar experience where they're making connections and communications around prevention and treatment of the physical health conditions that were addressed in your PCP's office. So far, does anyone have any questions, thoughts? You can let me know in the chat, or feel free to unmute yourself. Okay, I'll take the silence as a no. So moving on, now that you have effectively implemented construct 1, now we're advancing to construct 2, which is care management and consultation. So at this point, your organization is strongly committed to integrating your clinic by adapting a stronger screening and tracking processes with on-site care coordination and care management. So in this construct, you'd have to start making you have to make some infrastructural changes, such as hiring a behavioral health specialist or additional staff that can assist with the registry or on-site coordination. And now that you've hired a behavioral health specialist to be part of your team in the same office, and you have to have them actively integrated into your routine consultations to provide treatment services for the common and preventable conditions like ADHD, childhood obesity, breast cancer screenings, and etc., and monitor them and prevent them from worsening. Again, now let's flip the patient experience and see, let's flip the lenses and see what the patient experience is, right? So if an organization is actively building on the elements from construct 2, your patients and their families will start seeing that their service team is now working in a single location. Like that's when a behavioral health provider is on staff at your PCP's office, and they will experience that someone from your team establishes a personable relationship with them to help them complete simple tasks like completing their paperwork and helping them make appointments and more. And so these individuals will also be interested in improving the patient's overall well-being on a regular basis by walking them through the recommended strategies that the PCPs had given on whether it's lifestyle changes to find a new resource, or say the patient needs help in accessing transportation to make it to their next screening appointment, right? And this type of outreach, it truly improves patient compliance as they feel like the patient is being cared for because of the extra support, encouragement, monitoring, and the new coordination of care. So any questions? We have one more construct to go through. So if you guys have any questions, please do leave it in the chat or feel free to unmute yourself. Okay. All right, I think we're okay for now. Okay, so now that we've successfully implemented construct 1 and construct 2, you are moving on to the most advanced construct, few defined populations in the clinic. Construct 3 is geared towards managing a defined yet larger population of complex needs that can range from HIV care, asthma, to bipolar disorder, and even schizophrenia, right? So in construct 2, you start off small. So your defined population would be the fact that you're focusing on patients that have diabetes and anxiety, and then that's it, because you're starting off small. But here, you're going to take it a step further and you're going to tackle multiple conditions at the same time because you have a larger team and your population might need that extra care and intensivity of integrated service delivery. So typically, stage, the organizations are fully integrated. And as mentioned, construct 3 implies a high level of shared accountability since, again, it's a larger population that they are providing the integrated services to. So when an organization is at this construct, they also have the ability to measure improved overall health outcomes for their populations and take shared risks for cost and outcomes. And Kara, would you mind stepping in and kind of providing us with an example of this?
Sure. So when we're looking at our populations and looking at population management on this comprehensive level, we are identifying potentially several conditions that also are in great need for improvement within our clinic: depression and diabetes, children diagnosed with ADHD and adherence to the ADHD treatment plans, as well as understanding how helping manage this population can reduce cost and improve outcomes. A lot of times, clinics that are in this arena are looking at the total cost of care. And Sujina will talk about that a little bit later. But how do we reduce the total cost of care? How do we provide services outside of our clinics so that we can start to affect patients' ability to receive care inside our clinic so that they're not going to the emergency room for visits that are preventable, that don't need to be treated in an emergency room. So we're looking at an entire population. We're identifying, what percentage of that population is needing additional supports. And then we're implementing those supports in order to reduce costs and improve outcomes. And therefore, we monitor and track that along the way, and we adjust our treatments to improve those outcomes of the population and to increase percentages or decrease percentages based off of the goals that you set for your interventions and for the population. Was that good?
Yes, that was great. Does anyone have any questions about that?
This is definitely a different way than what we've delivered this, and I know that people are probably a little overwhelmed with a lot of information, but we would love to hear your thoughts and feedback so far. Hi, Mary Jean, you're still muted, but I can see you.
Okay, thanks. So we've looked at this and we appreciate the revision. Our issue is how to use these domains. We have a pretty solid integrated system, but we want to tie it to our specialty behavioral health differently within our larger healthcare system. And so we don't quite know how to use this tool to help us both get a sense of where we are with these different domains, and then figure out how to let the larger system know this is where we are and this is where we're heading. So if others have thoughts about that, it would be great to hear. Thanks.
So I would love to know if other people have thoughts about this, if they've looked at what this framework is and how they've thought through it within their system. And Mary Jean, I'd love to talk to you further about this, because I think it's different than just looking at the constructs alone, but looking at the domains within the construct, and I'm sure you've done that. And because this is so flexible, I think it's going to be based off of where you want to go, and then creating a plan on what steps you need to get there. So if you are looking at one of the domains and saying, like, we need to do better in the enhanced referral process within this domain in our specialty clinics, what are the steps that we'll need to take in order to make sure that we're more on the population management side? And I think Sujina is going to talk a little bit about that as we go into the domains. But the other thing that we're hoping to work on in the next, by the end of this year, the beginning of next year, is putting together a Project Echo on this, so we can have deep discussions around what's it mean under this domain to make progress, and how do we communicate to others that they need to support us to make progress in this. So I appreciate you bringing that up, and I will say we have no magical answers, because this is all very new to everyone. But I think this creates opportunities to learn together and see what we can do together.
Thank you, Mary Jane, for your question, and thank you, Kara, for stepping in. All right, so we do have one more part to this construct 3, which is the patient experience, before we move on to the domain. So I will, okay. So I want to flip the perspectives again to patient experience, and we want to know that once the systems are fully integrated, how does the patients feel and what's happening on their end, right? So, well, they starting off like families and patients, they will notice a higher level of teamwork, often in a single location, and they experience that all of their providers are in sync. Like I can't imagine, like every time I go to the doctor's office, I have wished like I if I can just stop explaining my situation over and over again to every specialty care, that would have been the best thing that I can ever do. And I think a lot of patients want that. They don't want to keep over explaining and repeating what's going on with their health. And so that's how they would feel once our systems are fully integrated. They'll also have more regular and proactive outreach by their service team to address the prevention and treatment of the more complex and comprehensive set of co-occurring conditions, by also assisting in their overall wellness and improvement, right? And most importantly, the care team, they're so good at their outreach efforts. They actively keep up with the patient. So say a patient missed an appointment and it's been a month you've heard from them, and because your care team is aware that the patient is a type 1 diabetic, they call them before they run out of their prescription or it's time for their next testing or screening, then rather than just letting it be. Right. And the way that I like to think about it is that construct 3 is about being provided services that are beyond the 4 walls of the clinic or the hospital. It's a continuum of care where they check in on you and make you feel like you're truly valuable. And in contrast with construct 2 is that they care and provide support for you in the clinic, and they kind of send you home with all the strategies and the resources pointing you in the right direction. But at the end, when you're home, you're kind of alone having to implement these changes. So there's no one that's calling you and be like, hey, have you tried those strategies? Like, what's going on? How has it been treating you? So in construct 3, the care team really tries to achieve that. And so that is the end of the constructs. And again, if you guys have any questions, please let us know in the chat, as we will be actively monitoring it. If not, I can pass it on to Sujina to talk about the domains and subdomains.
Thank you, Alina. So let's go ahead and talk about the domains now. And I want to emphasize this as many times as possible today, that this framework it provides flexibility so that both the primary care provider and behavioral health provider can utilize this framework to do their own form of integration. So if you're in a behavioral health setting, you're integrating primary care, and if you're in a primary care setting, you're integrating behavioral health. So as we go through these domains and subdomains today, I also want you to think about your organization and think about which statements on the tables that I'm going to show you in a few that actually reflects your current state of integration. Okay, so let's go ahead and, all right, so these are the 8 domains that IHCI framework has put together. These are evidence-based. We're going to go through most of them here with you all today. We have also put together a toolkit, which gives you thorough information on each of the domains. Unfortunately, we wouldn't have enough time to cover them all, but we're going to try our best to cover most of them with you all today. So let's go over and look at the very first domain, which is integrated screening, referral to care, and follow-up. So this is one of the large domain. So it has 2 subdomains, as you can see here. The first one is called screening for follow-up in co-occurring behavioral health, substance use disorder, physical health conditions, as well as preventive risk factors. So let's look at the traditional practice right here. And this means where we stand today, our current state. And the traditional way of providing care is that the patient, they do a self-report, right? They complain, they come in and complain that they are feeling sad or anxious. and so on. And the primary care provider might put you on an antidepressant or may tell you to go see an external behavioral health specialist and say that, you know, why don't you go and check and see who you can see under your insurance, and wish you good luck. And that's about it. There's no, you know, follow-up process in place, right? And then on the behavioral health side, the provider may just happen to take your vitals and notice that your blood pressure is a bit high, and then they tell you to go see your primary care provider about it. And but that's it. But there's no partnership there within the provider, so there's no systematic follow-up process. And then as we go through get more into the integration and at the first construct, which is screening and enhanced referral, this is where you really begin to incorporate any form of evidence-based approach, which is the systematic screening for high prevalence of behavioral health and physical health conditions and their risk factors. So, for example, in a primary care setting, you would be using PHQ-9 to screen your patients for depression. This means you now have consistency, and you're using some form of validated scale or measure. And then under referral and follow-up subdomain 1.2, at the first construct, you are going to have some sort of formal agreement between the primary care provider and the behavioral health provider, which is called Care Compact or an MOU, to be able to facilitate referrals, shared records, follow up on patients' progress, and so on. This way, you now have a recognized partnership with your primary care or your behavioral health provider to be able to facilitate those referrals and follow up, which means there are less chances of patients falling through the cracks. So that is the first construct of the very first. Are there any questions? I'm just going to pause here and see if people have questions about this. Okay. I'm assuming I'm doing a good job here. If you do have questions, please feel free to type in your question on the chat as well. And then now let's move on to the next construct, the second construct, which is the care management and consultation. So for the first subdomain, in addition to now doing the systematic screening, you are also providing education on physical health and behavioral health conditions. You are doing some data collection. You're tracking how many patients within your patient population are actually testing positive for physical and behavioral health conditions and their risk factors, and you're doing this in an annual basis. And that's how you demonstrate measurement-based care, right? And then under the referral and follow-up subdomain, the second subdomain under the care management consultation construct, you now have the capacity to actually hire a behavioral health consultant in a primary care team, or have a nurse or a care coordinator in the behavioral health setting. So, and then now you have a designated staff to track and follow up on every referrals that they've made, make sure that they happen. So this is more a step into an integrated care. So that is what the second construct is about for the first domain. Are there any questions before I move along? Okay, now let's move on to the third construct. This is when we get to this comprehensive treatment and population management construct, this is the most integrated you can get with your integrated services, right? So for the first subdomain, not only now you're doing screening, you have a screening tool, you have a system in place now, like patient to track your patients. You're stratifying, which means you're basically distinguishing how many patients have scored high in their PHQ-9s, who are suicidal. You're beginning to do more analysis on your patient population. Then under the referral and follow-up subdomain, the second subdomain for the final construct, you now have a solid electronic integration, which means you're getting real-time information on your patients because both of the providers are documenting at the same platform. Or if they're not using the same platform, they're getting real-time feed from other platform because there's a systematic, collaborative, and consulting partnership between the two providers, right? Along with the data sharing, and there's just more accountability for patient engagement. So ultimately, you can add value within this domain in terms of better patient outcome and quality improvement and some form of potential incentives that could also be recognized for those elements. So that is domain 1. Before I move on to the next, I'm going to pause here and see if people have questions. I'm not able to watch the chat. Kara, are we good? Okay. So then let's move on to the next. We're not going to go through all of them here, but I'm just going to show you what the second domain looks like. And for some reason, I'm not able to see the title.
It's evidence-based care for prevention, interventions of common physical health and behavioral health conditions.
Yeah. So this is a second domain. It's again, these contents, they're going to be very heavy today, and some of the domains have multiple subdomains. So we're going to provide you with the toolkit so you can review this at your own time. I'm going to pass it over to Alina now to talk about the next domain.
Okay, so the next domain is called Ongoing Care Coordination and Care Management. And the subdomain, let me see if I can get a laser pointer so you can follow where I am. So the subdomain is called Longitudinal Clinical Monitoring and Engagement for Addressing Prevention and Intervention for Co-occurring Behavioral Health and or physical health conditions. So looking at the traditional practice, it seems like there are none or minimal mechanisms for routine coordination and the follow-up of patients referred to the behavioral health care. But if we advance to the next construct, we see that providers for this domain, they have created a basic tool that track follow-up appointments, and there are some or minimal help in navigating the patients to their appointments and encouraging them to adhere to taking their medications. And I asked Kara what that means earlier, and she was like, adhering to take their medications is like a small commentary that they make when you get your visit summary. And they're like, hey, follow your treatment plan, or hey, make sure you take your meds. And that small statement, and then that's it, right? But if we look at the next construct, which is the care management and consultation, from the previous efforts, they have progressed, and now they have a team of members who can provide data analysis to guide the care and plan. So this is where the newly hired care coordinator can contact them to provide their routine care coordination and monitor routine follow-ups and even track patient engagement within the clinic. And so I thought it might be a great way to explain this domain to you through an example. So let's say we have a patient named Sally who is coming in for X diagnosis. And under the first construct, they learn that Sally might have depression, and the doctor recommends like, hey, maybe you should go see your therapist about that. And then under the next construct, Sally is actually referred to a behavioral health provider that Sally's PCP actually has a partnership with, and help Sally make an appointment with them. And her PCP's office is often in communication with the behavioral health services, and they learn about the medication she needs to take. And then with care management and consultation, Sally has care coordinators now helping her when she's in the clinic to talk to Sally, lighten her mood, or if she's feeling anxious about something, really just develop a personable relationship, assist her with treatment plans, and follow up regarding her medication and lifestyle coping strategy adherence. Now, for the comprehensive treatment, Sally's care goes home with her, right? So every few weeks, perhaps a BHC or even a nurse manager will call her and ask her how she's adhering to her treatment plans, if she likes it, or if she doesn't like it, then they suggest a new plan either on the spot, or they go back to consult with her PCP, and then they call back immediately, and it doesn't require Sally to come back into the clinic. And at this stage, they track how she's responding to certain treatment plans and also her outcomes over time. So that is domain 3. We have a question from Logan that says, could you expand the types of questions for data analysis aimed at care, follow-up, and tracking patient engagement?
Logan, can you unmute yourself and maybe state that question in a different way?
Yeah, I was just curious, I guess it varies across site, type of organization, but just like maybe ideas of like the questions that would drive, looking at care follow-up or patient engagement, because I think, maybe there's 2 different ways that can go. One's like looking at it patient by patient, doing analysis for that, and one's more like looking at the population level and seeing how follow-ups are happening. And, just like maybe talking about that a little bit.
Sure. So I think I understand what you're asking. And if I answer it inappropriately, you can tell me after I'm done. So I think what can happen under, when we're talking about population management and looking at data rather than just patient by patient data, you would want to look at it based off of a particular diagnosis, maybe. So it's always good to make sure you understand the diagnoses that your patients as an overall are the most prominent ones that your clinic is struggling with helping them attain positive health outcomes. So let's talk about depression, right? So if we're looking at depression, what the things that you could look at is the number of screenings you're doing on people that are diagnosed with depression. How many screenings you want to do a year? I know that, like, personally from my practice, because I'm diagnosed with depression and treated with depression at my PCP's office, they do a PHQ-2 every time I'm in there, every time. So what is your goal for your patient population to screen them if they are diagnosed with depression, right? If it's that we ask them a PHQ-2 at every visit, then for those diagnosed with depression, you would want to run a report that shows that you're asking that question or not. So maybe 50% of the time that happens, right? And so what you'll want to look at is like, oh, we're only doing it 50% of the time for this patient population. Let's have a goal to do it 60% of the time. And so you would set up processes for providers or their medical team to look at it to make sure that they understand that's a protocol that they have to do to improve that outcome. Does that make sense?
Yeah, that makes sense. Really tying the goal to the question, like, the percentage that you're trying to achieve based on the patient population.
Yeah.
Narrowing that focus.
Yeah, I think it's always good to narrow the focus. A lot of times when we do integrated behavioral health, we want to do all things all the time. And I know Sujina is going to talk about this later, but targeting your most common diagnoses rather than, your most complex diagnoses, because that's going to be a smaller segment of your patient population, but your most common diagnoses that integratedness can improve, will help you look at more of the population rather than just patient to patient.
That makes sense. Thank you.
Mhm.
Okay, thank you, Logan. Thank you, Kara. All right, so it's already 1, which is good, but we do have so much more to cover, so I'm going to move on to the next domain. All right, okay, so the 4th domain is called self-management support that is adapted to culture, socioeconomic, and life experiences of patients. And the subdomain is called the use of tools to promote patient activation and recovery. So this domain is actually one of the most underutilized when it comes to integrated care. In fact, in the traditional setting, there is none or minimal patient or family education about healthy behavior skills, and even risk factor screening recommendations. But if you move a step up, if you move a step up, they will provide you with a few resources, perhaps when they check you out again with your visit summary. You know, they can give you materials or handouts or web-based resources with the focus on referral to outside resources, right? But then move on to care management and consultation, is that you move away from the passive form of education, which is like giving them a bunch of papers and expecting them to read it, to active form of education. And this active form of education can happen either in person, if it means that you're helping them navigate through some sort of technological applications, like, I don't know, maybe like a really cool thing would be to have an Instagram account that is dedicated to anxiety management if they're a child or a teenager. Then there are also like these new things like digital exam room posters that a lot of PCPs use these days to kind of walk the patients through exactly what type of disease they have, how it affects them, where it is in their body. And it just really makes the conversations easier between the patients and providers. But ideally, at the end of the visit, you should go home with routine suggestions and strategies on how to take care of yourself. But keep in mind, like I mentioned before, like the way I just differentiate between construct 2 and 3, is that with care management consultation, the care kind of stops at the clinic, right? So they don't, they'll give you all the resources, all the education that you need, but it doesn't really go home with you. They don't follow up or question you on any of the challenges until the next time you're in the 4 walls of the hospital or the clinic. But then in the comprehensive treatment, the more advanced, the more fully integrated construct, there is a continuum of recommendations with strategies to improve the patient's own health outcomes. And here we're trying to help the patient to increase their knowledge, their skills, their efficacy to do certain things, their ability and their willingness to manage their own health by building healthy lifestyle habits. And you can call them and you can ensure them that if the patient is still on track with the healthy habits, and if they're not, you can also provide or make new recommendations for them to try. And in this step is also where you try to be on top of your screenings. You talk to them if they have like a severe illness, you talk to them about advanced directives, really just a great way to fully be invested in the patient, right? And I think a great example of this is to connect it to maternal health and postpartum women, right? So we all know that women, once they give birth to a beautiful baby, they go through a series of like hormonal changes and somehow they get into postpartum depression. And so it is recommended that during every stage of the pregnancy that the mom to be takes a PHQ-9 screening to scan them for or screen them for any depression, but this also applies after they have the baby. So this is where the mom comes in for her 6 weeks checkup, and then that's it. But ideally, you'd want to call her back and be like, hey, you gave birth like 3 months ago. How are you feeling? How are you due for your screening for PHQ-9? Have you been taking care of yourself? Because as a woman, I read and learned that after birth, it takes about 1.5 years for your hormones to go back to normal again. So that 1 year after 1.5 years after your pregnancy is actually kind of a very, very critical part of your overall health and well-being. And so this is all for domain 4 that I have for you. Does anyone have any questions? If you guys don't have any questions, I'll pass it back to Sujina to go through the rest of the domains.
Thanks, Alina. I'm also looking at the time and we're running behind a bit, so I'm gonna try and get through this not as quickly. I will be thorough, but just, do I have the control now? Yes. Okay. So this is domain number 5. It's called multidisciplinary team, including patients with dedicated time to provide integrated behavioral and physical health care. So this is a very busy slide. As you can see, it has 3 subdomains under this domain. So the first domain, it's called the care team. And this is all about having appropriate team member in order to provide the integrated services, which, the more care team you have in your practices who are working together to provide care to the patient, the better the communication is going to be among the team on a regular basis, whether that's through phone, electronically, virtually. The more advanced you're going to be in this subdomain. And then when you get to domain, the second subdomain, 5.2, which is sharing of treatment, case review, care plans, and feedback, at the first construct, this means there's routine exchange and release of information through phone, fax between the providers. In the second construct here, you go just beyond exchanging information now. The providers are actually going to communicate with each other, discuss assessments, the treatment plans. That is, could be either in person or virtually, phone, whatever means necessary. And there's a routine notes from the providers in the EHR system for routine reviews. Then when you get to the third construct, which is right here, there are scheduled meetings, which can be, again, in person or over the phone virtually, to discuss the complex patient cases. And you now have the capacity to get all information in one platform. You have the capacity of doing team-based care, all working together to figure out what is the best path forward for the patient, especially with multi-physical and behavioral health conditions like substance use, anxiety, diabetes. Providing integrated care, it cannot be one person's job. Like Alina mentioned earlier, you're going to need help, especially if you have patients with, multi-condition complexity. You often need everyone's help in order to figure out what is the best treatment option for those patients. Then when we get to the third subdomain, which is integrated care team training and competency development, this goes more into the training aspects of integrated care. So under the traditional practice, there's either none to very minimal training on integrated care approach, the integration of physical health and behavioral health. Then as we progress through these constructs, all the care team that you have under integrated care, they all require some level of training, and training according to disciplines, right? According to their roles and responsibilities, because guess what? As you are progressing through these constructs, there's going to be higher expectation from your team. Everyone has some level of accountability for patient care, and that requires adequate trainings, competent trainings on integrated care concepts for screening and referral workflows. integrated teamwork with defined, responsibilities and roles for each team member, and routine integrated team process in place, like team huddles and team care team meetings, and other ongoing trainings on all levels of staff. So that is domain number 5. Are there any questions before I move on to the next one? Okay, I'm going to move on to the next. This is domain number 6 and 7. Again, we're going to provide you with the toolkit, which has all of these domains and subdomains listed. I'm just going to skip to the very last one here, which is going to be financial stability. So this domain is all about financial stability, which is obviously a very important one. And I wanted to make sure I cover this with you all today. So it has 2 subdomains. One is building a process for billing and outcome reporting to support financial stability for integration efforts. And under traditional practice, there's none to, again, minimal attempt of to bill for co-occurring behavioral health or physical health screening, prevention, interventions that take place on site. The integrated services are usually labeled as special services, like a pilot program, that are supported by the grants, but there's no process in place for sustainable funding. And so this ultimately results in program shutdown because you ran out of the funding. And as we move along these constructs, there's better process in place where you're able to generate fee for the service you're providing, like billing for physical health and behavioral health screening and treatment services under the fee for services. And you're able to track reimbursements for those services, right? And you're building a process to make sure you have a fee capture for the services that are reimbursed using the CPT codes. But just that is not going to be enough to financially sustain. So you need to move on to develop that capacity through, outcome reporting to get incentives, and then potentially building on value-based payment mechanism with payers, with state providers, so that we're really getting all of the financial support that we need after all the investments that we've made. And then on the second subdomain, which is building process for expanding the regulatory licensing opportunities. So this is depending on your state. You may require additional certification in order to operate under the integrated care and also to make sure that the services that are provided by those individuals is actually billable and reimbursable. And so at the current state right here, providers have very limited understanding of how to provide integrated care or how to document for the services that they provide. So at the traditional and the first construct, right, in between these two, you are utilizing the existing physical health provider's license to get reimbursed. And when we move further up towards care management and consultation, that's when you're ensuring that the behavioral health provider are part of their primary care team. They are appropriately licensed, appropriately credentialed through Medicaid and other payers, so that the clinic can get reimbursed, not just for the physician's time, but also for the behavioral health provider's time. And then when we get to the comprehensive and treatment population management, which is right here, we're making sure processes are in place for all area of the clinic, establishing procedures so that we're consistently billing, we're consistently able to bill and get reimbursed for the services that we're providing. And that includes making sure that people within your billing and coding department, they actually understand all the codes that can be used in integrated care, and that they're helping to ensure that the electronic health records has the right workflow to support and promote the code usage that reflects the work that's been done in the clinic, a smooth process in place so that the providers can, provide the care and are able to easily document through the EHR on the services that they provided, so that once that gets to the administrative side on the administrative office, they really do understand the way the care is being delivered so that they can optimize the code usage. It is also about making sure the clinical licensure requirements for your state or your license actually has clear and consistent protocols. And you're making sure that you're ahead of meeting all of those requirements, and so that you're able to support integrated care for the population that you serve. So that is the final domain, financial stability. Before we move ahead, are there any questions?
I think for the sake of time, we'll just move on. I don't see anything in the chat. And so we'll move on to the next part of the presentation, which is metrics for integration. So this is where we're going to start talking about what it means to demonstrate value. And so this demonstrating value for the CHI framework can be answered in the one simple question. Not answered, but it's kind of like addressing this one simple question, like how do I know if the patient got better? So we can start by putting a definition to the value, right? So value is the measurable improvement in individual or population health, whether it's a behavioral health or a primary health care outcome measured with increased equity and quality in the relationship to the expenditure. So for most services and populations, trying to implement integrated services may involve increased costs, but improved health outcomes would mean that you're outweighing the additional investment by demonstrating value. Or you can be a clinic that already has high costs and poor outcomes, and this in fact might be reducing your expenses. So if you're going to put your money into this, you need to be able to see a positive return on whatever that means for you. So in order to start demonstrating value, you have to start off with picking your population. Kara kind of spoke to this already, right? You cannot pick all of the, choose all of the conditions as your defined populations, but you have to start small and choose one or two, like sticking with just anxiety and depression, or just anxiety and cardiovascular health. Or you can just identify your conditions looking at what your clinical population, what's most prevalent with your clinic population. And then you implement those measurable indicators of integratedness and the relevant outcome measures for those conditions. And I'm gonna skip over this slide because I want Sujina to talk about how you choose those metrics. So when it comes to choosing metrics that demonstrate value, it's all about a shared process between your providers and your payers. You really have to sit down with them and discuss like what is the most important and what exactly would you like to target at your clinic. It can be either breast cancer screenings because a large percentage of their women are over 40. Or it can be colonoscopy because a large percentage of their men are over 50. But the goal is to choose a balanced set of process and outcome measures, right? So as mentioned earlier, you can choose whatever metrics you want, but you have to make sure that it is prevalent and applicable to your clinic. So the end goal is you want to choose something like either one or more metrics focusing on prevention or treatment on physical health condition, or one or more metrics focusing on prevention on behavioral health condition, or both. And Sujina will go over examples of what that means.
Thanks, Alina. So let's go. I don't know what it's doing. Okay, can you see the metrics one? Okay, so let's get into the metrics. So if you think your organization, they fit under this first construct, then you will need to think about how you're going to demonstrate value under this construct, right? So screening and enhanced referral, it has value. There are studies that have been done that shows that if you actually screen and track the referrals, it will result in value for the patient, for the providers, and for the payers. And here are some of the things to consider. These are some really good examples that they provided at the IHCI framework. So I just wanted to share this with you all. So if you're in a behavioral health setting, you need to think about the screening rates for heart disease or diabetes for the patients with severe mental illness. And you need to think about what does those screening rate looks like. And then demonstrate that you have at least one care compact or an agreement with a primary care provider to provide that physical health care, right? So then you're covering both aspects, and show what does the completed referral rate looks like for that. This is how, you know, you bring value. By doing this, we know that more people are getting connected to care. We know people are getting better. And then on the physical health setting, you need to think about the screening rates for depression, anxiety, substance use disorder, and again, demonstrating that you have at least one care compact or an agreement with a behavioral health provider to appropriately treat your patient with behavioral health needs as you have that partnership with them. Then you can look at the percentage of those patients who actually completed the referral. So you now need to have a process in place that enables you to track and see if the patient actually showed up or was it a no-show. So construct one in that aspect is incredibly valuable because you now have data, you have numbers to show to the payers and ask to pay you a case rate, so you can afford to hire a dedicated staff like a medical assistant or a care coordinator who are, you know, who would be responsible for doing those screenings and making sure that the referrals are getting where they're supposed to go. Okay, so that's a good example for metrics 1. Any questions? Let's go through the metrics for construct 2. So for construct 2, you can use metrics for from construct 1, but here you're going to take a step beyond, right? So in behavioral health setting, you can track how many patients with high BMI were offered nutritional counseling, and what's the percentage of that? What's the percentage of patient with opioid use disorder? And that actually applies to both physical health and behavioral health setting. And you need to track what was your retention rate for the 6 months, 12 months, and at 18 months. And what is the percentage of patients of glucose control for patients with severe mental illness and diabetes? And then in the physical health setting, we're focusing on the percentage of depression symptom reduction by utilizing a tool like PHQ-9 at 6 months and then at 12 months. And how many of those patients reach remission of depression symptoms in primary care? And this is how we're demonstrating value here. I mean, here we're talking about changes, right? We're talking about direct clinical interventions. And now we have hardcore metrics that we can demonstrate value that we are bringing because of our integration efforts at Construct 2. So this is just an example. Again, in your organization, you need to think about your own patient population and look at some of the potential metrics, come up with your own metrics that suits your patient population based on how you have designed your integration program. And then lastly, metrics 3, and this is a little up there. It's, you know, we're going to have to toughen up a bit for this construct because in this construct, you're not just doing the metrics, but you're also demonstrating reduction on ED utilization, hospitalization, and readmission. You're also looking at follow-ups, and I mean, these are really up there, but they do also impact the cost of care, right? I mean, there's always going to be a need to use emergency department and the hospital, but you need to think about what is preventable. And when we're looking at reducing depression and then therefore reducing suicidality, that's a possible preventable visit. And therefore this is really focused on the total, you know, the total cost of care, which is what Alina was actually mentioning earlier, what the comprehensive treatment and population management should be focusing on. In addition to improving health outcomes and improving patient satisfaction, we're also reducing the cost of care. Our service, it shouldn't just be within the 4 walls. Again, I'm echoing Alina's word here. When we have engagement outside of our 4 walls, and then we can have better relationship with our patients and help them navigate through the most cost-effective and the most healthiest way to engage in care. So again, this is just an example. I just wanted to put it up here for you guys to see what the metrics would look like under these constructs. But you again have to think about your own patient population and think how you would be able to demonstrate value based on what you're doing, the type of integration that you're doing. And with that, we are at the end of our presentation. I'm gonna stop share and see if people have questions. We have 1 minute left.
I think that's pretty impressive that we contained everything in the hour and a half we were given.